Welcome to the Prime Health Podcast with your host, Dr. Derek Barron. Dr. Barron interviews doctors, wellness experts, and healthcare leaders who are revolutionizing how we approach health and longevity. The Prime Health Podcast explores breakthrough science, personal and patient stories, and practical insights that are shaping the future of health and wellness. So sit back, listen in, and prepare to transform how you think about your path towards Prime Health with Dr. Barron and his special guest.
Welcome back to the Prime Health Podcast. I'm your host, Dr. Derek Barron, and I'm here to bring you cutting-edge insights and practical strategies from leading healthcare experts for your journey from Prime Health in life and business. Now, today's episode is particularly exciting because we have Dr. Phil Hellman from Paradox Health. But before we dive in, a message from our sponsor, Grow Solutions, because brilliant healthcare professionals shouldn't have to choose between patient care, practice growth, and a living style that allows you to have your own Prime Health. With Grow Solutions, we eliminate some of the biggest headaches that involve in practice: patient communication, new patient lead generation, operational chaos, using proven systems and frameworks. And yes, of course, we implement AI systems and agents to allow you to enjoy your practice and life again. So Grow Solutions is not an agency or a vendor. We are your growth partner. So if you've ever said this or thought this, I'm too busy to grow, too slow to scale, or too overwhelmed to fix it, we can fix that for you. Just drop the word grow and below in any of the comments, or feel free to reach out to me on any social platform. But today you're here to see our guest on the episode, and I'm pleased to introduce Dr. Phil Hellman, a board-certified family medicine physician and leading expert in direct primary care, longevity, and regenerative medicine. Dr. Hellman is the founder of Paradox Health, where they specialize in direct primary care, and Paradox Health has been open for 12 years and started offering regenerative therapies back in 2019. Dr. Hellman has helped many of his patients recover faster and avoid surgery. He is also a 3-time speaker at the Direct Primary Care Summit. Dr. Hellman, welcome to the Prime Health Podcast.
Great to be here, Derek. Thanks for having me.
Absolutely. My pleasure, my friend. So I always ask this at the start: was there a moment in life or a circumstance that may have kind of came up in your lifetime that chose you to go into medicine?
It wasn't really like one moment. It was more of just a series of events that kind of led me in that direction. I did some mission work in high school in Peru and Costa Rica that really just kind of solidified my desire to kind of help people in a more direct manner. And then just things in medicine, things in science classes kind of came easy to me. I took anatomy in high school where we dissected a cat, and I never really had to study for it. I could just kind of memorize the terms. And so things like that kind of pushed me in that direction, and kind of, that's where I ended up.
Yeah. Well, I'm sure that I was on a mission trip myself in Haiti, seeing a completely different situation when you see people that really need and have the needs, and you see that in third world countries. I commend you for doing that from an ethics and integrity standpoint. So I appreciate that. Now, in your community or any community across the globe, essentially, especially here in the States, there are primary care physicians in a hospital setting or in a clinical setting, and there are what are called direct primary care physicians. Can you explain what that is and the difference for our viewers and listeners?
Yeah, so I'll try to be pretty succinct about it. Direct primary care is kind of like affordable concierge medicine. So we don't bill insurance companies for anything. Our patients pay us a monthly membership fee, and in exchange for that, they get time with us, and they get discounts on things like medications, labs, and imaging at cash pay prices. So we have full transparency of prices throughout, and our patients get, more time with us. They get better access to us. We have same-day appointments for patients who are sick, and then they also get the cost savings. So like I said, we make a point of it to be affordable. We think that just about anybody can pay for us. Our memberships are less than the cost of a cell phone bill. So.
That's incredible. That's I love the way you explain that from that perspective. As from the financial perspective, less than a cell phone bill, that's amazing, especially when you get direct primary care. Now, how do you think that do you believe that there are more physicians kind of morphing into direct primary care, and how do you think that'll impact the American healthcare system?
Yeah, so I think it's really taking off right now, and I've never said that before. I started in 2018 because I saw people not just searching for something different, but actively, not just talking about the need for something different, but actively searching for it. I had people saying, do you know a doctor that does things differently? And that's when I started, because I thought the demand was there. The biggest problem has typically been getting doctors on board, so that's really the bottleneck to direct primary care opening up. And we see a lot more physicians now jumping on board. It used to be less than 10 around the state, the whole state of Michigan. And now there's tens of doctors that have already started, probably under 100 still, but enough that I've lost track. And I don't know all of them personally. And there's been a few meetups or like networking events for docs that are interested in direct primary care that I've gone to. I just went to one about a month ago, and there were probably 20 docs there at a restaurant in Bloomfield Hills, suburb of Detroit. And so I was just shocked at how many people were people who had started a direct primary care practice close to me that I didn't know about, or people that were planning on starting one, leaving their hospital employed position typically and starting their own direct primary care practice. Also, just the direct primary care summit that you mentioned that I've spoken at a couple of times, it's been growing every year. This past year, we had like around 500 people sign up and around 700 docs actually attend. So it's kind of growing 30-50% every year. And I saw people from my medical school there. I saw people from my residency there, which is, if you go to residency with, even if it's 25 other docs, the odds of seeing somebody at a direct primary care conference pretty low. And so it just goes to show that people are really, it's catching on. Most docs actually know what it is. The other factor at play is before this year, HSAs have been sort of taboo in terms of using them for direct primary care. So the law is sort of ambiguous. Essentially, the IRS is not coming after people for using their HSA for direct primary care, but there is no law that specifically allows for it. And so a lot of companies have been unable to create plans for their employees for it, especially if they're more scrutinized by the SEC, like, for instance, a public accounting firm. And so now, although I'm not a huge fan of spending lots of money, this new bill that's being introduced by the Trump administration includes language to allow for the use of HSA to pay for direct primary care up to $200 a month for the membership fee. So that covers, I'd say 99% of direct primary care practices.
Do you know if that's going to be across the board on all insurances, or is that coming from a Medicare, Medicaid standpoint?
No, yeah. So that's if you have an HSA qualified insurance plan. So typically that's a private plan that's going to be either through your employer or something that you get with your insurance agent or through Marketplace. So it has nothing to do with Medicare or Medicaid. But if you have an HSA or FSA qualified plan, you can use those HSA dollars on your for your direct primary care membership. And it's sort of set in stone. We've been doing it with our patients since we started. But I really just think that, a lot of people are kind of after those HSA dollars. And so it's going to really take off.
Yeah, it's very beneficial for the patient to allow them to use it. Right. I know some are like, for hours with our HSA, we've tried supplementation on it. There's no kickback unless it's somebody that's auditing that says, hey, what are you doing this for? So I think it's for the better of good. And, that brings up a question to me, Dr. Hellman. Like, what do you feel is the biggest misconception about direct primary care out in the marketplace?
I think the biggest one we still run into is just that it's concierge care. that it's medicine for the healthy and wealthy and nobody can afford it. And nothing really could be further from the truth, because we actually think we're more affordable lots of times than just seeing your regular insurance-based doc.
Yeah. Now, you've been doing this for some time. How do you, when I say the word time, I think that plays a big part in it, because typical care in a hospital setting or a clinical setting, 7 minutes, maybe 10 minutes max, you get to spend your time with your physician. How do you feel this direct primary care model is allowed to take better care of your patients?
Yeah. So, just being able to answer everybody's questions in one sitting, not having them, hey, we can only deal with one problem today. You got to come back if you want this other problem addressed. In the end, patients are happier and doctors are happier. And so I think what the system does is it creates this artificial friction between patients and doctors, because in the system, the incentive for the doctor is to get through patients as quickly as possible when the patient wants them to slow down and answer all their questions, and they just can't. And so they end up kind of at loggerheads with one another, even though really all that's needed are those two people, right? You don't need anything but a doctor and a patient to make something happen, but it's all of the administrative pressure on the docs, a lot of it, creating this unneeded pressure to see people quickly, and that creates, a lot of the problems. So, we're able to spend more time with people. We can diagnose things that we otherwise couldn't, because we have that time. We don't have to send people to specialists as often. We're able to keep people out of the ER, out of the hospital, out of more surgical options, by looking into other therapies, bring more things on board. If we brought an ultrasound into the clinic and I didn't have to ask my boss to purchase it, I just bought it, because I wanted to do it. And then I went and paid for a course to learn it because it's better for my patients, whereas a lot of docs are going to hesitate to do that because it's going to cost them out of pocket, and they're going to want the hospital to pay for that education. I don't have that option, so I just have to do it, find the best option, pay for it, make it happen. Actually, I have some friends that went to a point of care ultrasound course, and the other docs there were all hospital employed, and they're like, "Who are you guys?" And they're like, "Oh, we're direct primary care doctors. We just paid to come here out of our own pocket." And all these other docs were like, their minds were blown. Like, you paid your own money to be here? Like, yeah, because it's a course where we learn about how to take care of people. Like,
Yeah.
of course. So it really flips the script on a lot of things. One great example is somebody comes in with radicular pain. Insurance wants you to get an X-ray right away. Even if they've got numbness and tingling in their foot and they've got a foot drop and they need an MRI. We just do the MRI. The MRI is $300. If you go get the X-ray through the hospital, it's $600 through their insurance.
Yeah.
And so it changes how you practice medicine when the cost structure is laid bare.
Yeah. Do you get pushback from fellow, physicians that are in the hospital that you're cutting into our care, or do they not necessarily notice it?
Not yet. I think that'll come eventually when we're big enough, but right now the hospitals really aren't paying any attention to us because we're still kind of small potatoes to them. Okay. Right. And I think that they're all struggling too. I mean, even though hospitals benefit from high prices and they're all consolidating and they seem like this big evil corporation, there's also hospitals that are still losing money every year. Still a tough business to exist in. And I know Blue Cross Blue Shield of Michigan lost millions of dollars last year. Even though their premiums go up every year, they're still struggling. It's just such a complex thing.
Yeah. Something's got to change from the top down overall. I think the way that you and other primary care docs are doing this from a direct primary care perspective is a great way, because it's from the bottom up. It's the patient first and everything else comes.
Yeah.
At least that's kind of my thought process on it. So you had mentioned that you have an ultrasound unit in your practice, and I assume you utilize that for musculoskeletal injuries or when you start to implement regenerative medicine to the practice. Would that be true?
Yeah. I mean, we utilize the ultrasound for a lot of things. We use it to diagnose pneumonias now. We don't even send people for chest x-rays most of the time because it's so much more sensitive for it. But we're certainly doing joint injections with it, of course, and we are doing, the regenerative therapies that we offer are prolotherapy and PRP. We haven't invested in a stem cell setup yet. I think that's something that could come with time, but it's tough. It's the law of line extension, right? In the rules of marketing. So I don't know that we want to extend ourselves quite to that arena yet, but we do a lot of Prolo and we do some PRP. I mean, we only have 1,000 patients, so we don't have this massive population that we're drawing from, but we have phenomenal success with both. And we do probably the most amount of Prolo that we do is really for tendinitises, which of course the most common ones that we see are golfers and tennis elbow, medial and lateral epicondylitis. And we kind of have basically an easy protocol of just prolotherapy and PT, with prolotherapy being about every 3 weeks until they're better, until they're essentially 100%. And it kind of works every time.
That's a good outcome.
I've done PRP for it as well, and I haven't necessarily gotten better results. Just trying to save people money. Our prolotherapy is free and our PRP is $500. So why wouldn't you have them do the free option?
Start with that first.
And then we're doing a lot of PRP, ultrasound guided PRP for arthritis, hip injections, knee injections, shoulder injections, things like that.
Cool. From an overall perspective in the practice, conditions that walk in your door, pneumonia to regenerative medicine, you see the gamut of it?
Yeah. I mean, right before I got on this call with you, I was seeing a kid who just got a laceration over his eyebrow playing football on Friday and was checking that because the glue was falling off. He had gone to an urgent care and got it glued when it probably should have gotten stitched. And then I got a pneumonia case in the afternoon coming in, or what we think is pneumonia, and just saw another kiddo for like a full body rash, and had a lab review before that. So it's primary care, right? I mean, those are all things that should fall under the purview of primary care. And unfortunately, we've kind of gotten away from the old style primary care where they took care of the majority of things and only sent things off to the surgeon when they really needed it. Now it's really, the primary care is more of, as far as I can tell, in most urban areas, just sort of a referral machine. So we try to refer out as little as possible. That's really, only when it's appropriate, when it's needed. I joked around with a pediatric neurologist one time. My daughter had to see a neurologist for some headaches she was getting, and he was just sort of commiserating with me over how many referrals he gets for unnecessary things. And he looked at me, he said, "I just got a referral the other day for a 1-year-old who couldn't walk." When clearly, you don't have to walk at 1. You can walk at 15 months. You can walk even at 18 months. Really, it's not a big deal. Right. You never met an adult who couldn't walk because they never learned how. So there's so much over referral, and when you look at the cost in the healthcare system, like we were referring to before, that referral's $350, $400 to the system. Anyways, it's great. Direct primary care, it really allows you to just expand your scope, take better care of people, and it might not be the best way to make money, but it's certainly a better lifestyle and a better kind of way to stay both mentally sharp and mentally well.
Yeah. Yeah. From your business as a direct primary care physician and what you're doing in your community, what's the focus of your business right now?
Well, as far as developing my business,
sure.
Yeah, it's hiring more docs. Yeah, because you can either, two ways to make more money is you either raise your prices or you scale. And if we raise our prices, part of that would be turning people away because we kind of cap ourselves out around 500 patients per doctor to keep the quality up. So if you go beyond that, inevitably at some point you're not going to be able to see as many, not see as many people, but take as good of care of the people that you have. And so we try to cap ourselves off and then hire more people. And so, like I said, thankfully the flow of docs into DPC has definitely gone up. So we've got some candidates that we're talking to right now and potentially going to be hiring next summer.
Excellent. Well, congrats on that and the growth as always. You had said that you were with a kind of a meetup of some of the doctors in and around the area. What do you feel the challenges are for people in the DPC arena in practice?
Debt.
Okay.
That's it. I don't think there's not much else in terms of a roadblock from keeping people from doing it. But if you think of the narrative of the typical graduate from residency, are on average going to have, not on average, but the range of debt is probably anywhere from $250 to greater than $500,000. And so then you look at the offers on the table. Well, you can go work for the hospital that's going to pay you a $60,000 signing bonus. It starts you out immediately at $230,000, $240,000. You could go do rural medicine and make more. They pay more for where it's harder to recruit physicians in.
Okay.
But you're still, you're hospital based, you're insurance based. Or you could go work for a private practice, kind of similar deal. But it might also be, maybe you get a signing bonus, but it's only eat what you kill, meaning you only get paid for the people that you see. And you'll have insurance sending you patients and you'll grow rather quickly, but not quite as quick as at the hospital. Or you do DPC where we say, hey, we can pay you, a resident's salary until your panel grows up to a certain point, because I can't give you a signing bonus. I don't have that kind of money. I'm not taking out a $250,000 business loan to pay off your medical school debt. So it's really, the hospitals have the leverage when it comes to hiring.
Yeah.
But then that doctor is burnt out after a year and a half. So
yeah. No autonomy in that setting. It's, do what we say to do. That's a difficult situation.
Yeah, it's worse and worse and worse. And it's not just the administration, it's also insurance companies. There's a local practice I was actually just talking with a patient about. He used to go to this practice, it's a big physician group, and they were all mandated to get the COVID vaccine, the doctors were, and they were being mandated that all of their patients had to get it by the insurance companies. Right. And so a number of those doctors left because they didn't want to get the shot, and the practice really suffered from it. The docs that were left, had to take on all those patients that wanted to stay with the practice. So you just, the levers of power they're interesting. And, I had another friend who went to go work at a hospital in small town, Minnesota. And he liked it. He had, good autonomy and a lot of respect at the hospital. And then the hospital got bought out by Mayo Clinic. And he told me it kind of went from, hey, let's see at like committee meetings, hey, let's see, what the doctor thinks about this and get his input, to, when Mayo bought it, it was, okay, this is what you're going to say.
Yeah. You're a referral engine, really, is what they wanted to go to the Mayo Clinic.
Yeah. I mean, hospitals lose money hand over fist on primary care. They don't know how to make money doing it. And their business model is just get your primary care to refer to the specialists that make the money. And that's how we make our money.
Yeah. Yeah. Not with the patient end in mind, that is for sure. So again, DPC care is new and upcoming. It's been around for a while. People are understanding it. What do you think you do in your practice to build trust with patients that allows you to be successful?
It's honestly not hard because the bar is set so low. If you hang out with your patients for 10 minutes and tell a few jokes, and you don't rush them out of the room, that's about all you have to do.
Yeah.
Just be nice and be available. I think that's a big one. If you call people back, they really like that.
Yeah.
And most docs, it's not that they don't want to, they just can't. It's like a survival mechanism. They've got all these kind of barriers up in front of them to keep them away from their patients because they've got on average 2,500 patients per doctor. And they couldn't do what I do with that many patients. So they have their medical assistant, their front office staff kind of keep them at arm's length. And nobody likes that. It's a very impersonal kind of system. So again, it's not a lot of effort. You just got to kind of be yourself and take good care of people.
Yeah. It's what you went into medicine to do, is that's all you're doing in your practice. A patient walks in, you listen to them.
It's pretty easy. Yeah. And we don't do anything radically different. We're not treating everything with herbs and supplements. We're doing a lot of bread and butter primary care. But when you do it sort of differently, people enjoy it more and they realize, that's the number one reason in surveys why people seek out alternative medicine is simply that those people spend time with the patients. It's the time. It's not necessarily that they don't trust what you're doing. Or rather, maybe the time builds the trust. So,
yeah. So can you, Dr. Hellman, can you share a success story of a patient that maybe came from typical healthcare in a hospital setting and how you made a difference in their life and had a great outcome with them?
Yeah. Gosh, I'm trying to think about, which one. There's different success stories. There's people that maybe got a diagnosis that other people couldn't come up with because they didn't have the time. We've had a number of those. We've also, one of my early patients came to me, she was post-heart attack and she was uninsured and she was paying cash for her prescriptions outpatient from the hospital. She paid something like $140 for a 1 month supply of 5 generic medications. And I did a price comparison. And because we actually buy medication from wholesalers and then dispense it in house, so she was on typical stuff: post heart attack, aspirin, Plavix, cholesterol med, 2 blood pressure medications, and I think it came out to $70 for the year for all those medications. And so, her cost savings in medication paid for the membership just itself. I've got another guy, maybe a recent success story. He had a traumatic brain injury and he was just not feeling himself. We ended up checking his hormones and they were all off. Like his pituitary was just screwed up. And we got him on some Pregnal, some HCG, which helps stimulate testosterone production. And he and his wife, had actually been trying to get pregnant for a couple of years and they couldn't. And it was as soon as he got on the HCG, it changed his brain chemistry. His estrogen levels came up, his testosterone came up a little bit, which it needed to. He felt better. He wasn't being short with his wife and his kid anymore. And his wife got pregnant. He called me up. I was like a couple days after his first injection. And he's like, "You're not going to believe this."
That's a great success story. My wife and I, we had to go through some IVF to have our child. So it's whenever you can help somebody in that situation, you feel as though you're in dire straits. You just don't know what to do.
Oh, yeah.
So that's I can appreciate that completely. So Dr. Hellman, where do you see the vision for your business in the next 3 to 5 years?
Well, I think it's just adding on a few docs. I think we can take about 2 more at our location, and then it might potentially be growing to another location if the demand is there. So it's been kind of a slow organic growth. Some people kind of start out with a bang and, they might take out a business loan or something and start up even multiple locations at one time. There's also like a corporate side to direct primary care where people do on-site docs for businesses that have, a couple hundred employees. Those guys grow pretty fast. There's one called Nextera Healthcare that's kind of all over the country, really. But we're kind of more the sort of, grassroots DPC growing slow. But yeah, I think I definitely see us with a couple more docs and hopefully they'll be full by that time.
Cool. So a time to brag is somebody that kind of led the charge in your community from a differentiator standpoint. What do you feel, Dr. Hellman, that you do better than anyone else in your community in regards to primary care?
Yeah, I'm not so good on this question. I mean, I think in the end, it might just be the range of things that we offer. Some of that has to do with the training I got in residency. I was trained in kind of a rural medicine, family medicine program with like surgical OB. I was doing C-sections and tubals and things like that right out. So we do a lot of procedures. We do cyst removals, lipoma removals. Like we talked about before, the regenerative aspect. There's not a lot of family docs doing that. I know you said you didn't know a whole lot of people doing prolotherapy. Yeah. I don't see it either, and I don't know why. Dirt cheap and super effective. So yeah, I think at least on the procedural standpoint, I think that really sets us apart as far as what we offer. I know a clinic, I have a patient who works at this clinic. She's a nurse practitioner, and they sort of brag at the clinic that the most advanced procedure they do is an earwax removal, which my medical assistant does. So really, I just think the value that we offer is pretty high. We're not just suturing people up. We're also taking up big lipomas off people's abdomens and, doing all sorts of stuff like that.
Yeah. Well, I'm sure your community truly appreciates that. Now, we'll share all of your links to people to contact you, website, all those kinds of things, social media contacts. But if somebody is interested in learning more about you and your practice, where do you suggest they go?
Our website's really the best place to go, which is just paradox.health. Paradox, Paradox. And that's got all the info on our clinic. We've got an Instagram account that's been lately a little sleepy, but we'll probably wake back up here pretty soon. But it's got a lot of good content from the past on it. So just some cool posts and interesting things related to both DPC and regenerative medicine. So that's another good spot.
Cool. 2 more questions for you. If you could give anyone watching or listening to this one piece of advice that affects their overall health in a very positive way, what would that advice be?
Probably that exercise is the most important, or rather the biggest pill you can swallow.
Okay. Yeah, people don't like to swallow the pills, and most don't like to do stairs or steps, but it's very key, very critical. Yeah. So I appreciate that. So you are on the Prime Health podcast. As we wrap up, I'd love to get your definition of what you feel Prime Health is.
Well, I think it's pretty customized to each person. But I think as long as if you take the time to identify the risk factors that you want to minimize in your life, and you're taking the maximum amount of effort to minimize those things and maximize your health span, how you feel, I'd say that's a pretty good definition.
Cool. Love it. Well, Dr. Hellman, thank you very much for your time today. I appreciate you taking out of your midday. I always tell people that, of course, you and I would like this information shared, because not that we have egos, but we think it's important for people to hear it, see it, learn more about it. But I think it's very critical for those who have listened to this. If you got something beneficial out of it, send it to a friend or a family member, especially where people are, where Dr. Hellman is in Michigan, because there's somebody that can benefit from this. They don't know that there are better options for them than just going to the hospital, getting caught up in the hospital setting. Yes, they have their place. But I think Dr. Hellman's clinic, being a DPC clinic, is a great aspect for people to take advantage of. And, I'd love it if you'd subscribe to our podcast. We always want to help more people learn. So until next time, remember that true wellness is a journey we are all on together. So whether you're taking charge of your your own health or guiding others in theirs, every step forward matters. So I always say, stay committed to your Prime Health journey. And again, Dr. Hellman, thank you very much for your time on today's podcast.
Thank you so much, Derek.